things happening all over. So Dr. Wendy is started her standalone practice how long ago?
You mean like the brick and mortar or
Your brick and mortar practice, yes.
Oh, that's October. So it hasn't been that long.
Hasn't even been a full year that she started her brick and mortar practice. And that little strong woman was carrying a piezo wave all over Colorado, and now she can stay in one place. What a concept.
It's kind of amazing. I forgot. What did I took it so, I did a lecture with the piezo wave a couple weeks ago, and I had to box it up. I forgot about this. The tech who works with me didn't even know how to box it up. She's like, I've only done it was like a year ago. Remind me how to do this. Yeah.
Yeah, and we're gonna make a recording of that presentation at some time. Your piezo discussion. Did it go over well?
It was terrific. It went great, and it was nice because I decided kind of the take-home points. I'm trying to partner with a local GP to have the doctors refer to my practice for what I'm calling shockwave only cases. And I'm doing it as an experiment because the owner of the practice is a good friend of mine. So like communication is easy. We're trying to like work out the kinks. But what I ended up focusing on, Cindy, was osteoarthritis. And the take-home message was, look, you guys see these dogs when they're so young, and it's a young dog disease, and you're catching it so early. And so I catch it late. By the time dogs get to me, they already have clinical signs typically. And so if we work together, you identify early, you send it to me, I can do all the prevention with Shockwave, which I believe is our strongest tool for preventing progression of OA. And we can work together to get these really good outcomes. That ended up being like the core of the talk, which I thought was really important. And I love the idea. So that just happened, a month ago. And I'm actually getting to work on one of the doctor's dogs, which is the best way to show them what we do. So I'm really lucky. And so, yeah, there we go. I'll talk to me in 6 months. I'll tell you how many cases we get out of that. But I really do think that if you want to be gold standard for OA care, you need to be getting Shockwave on a regular basis. And so to bring the GPs in, I think is an awesome idea.
Yeah. Because it gives them an option other than NSAIDs, right?
Yeah.
What is a regular basis?
That's a great question, Bevette, and there's not a lot of literature on that I know about. So to be honest, I'm just talking with other practitioners in my experience. What I'm recommending is we do your initial series and then we follow you up every 6 months. If I have a really advanced case, like I have a really bad bilateral hip OA and a young dog, I'm actually treating him every 3 months. And then how many do you do in a series, right? Like that's like another big question mark for us that we don't have a lot of literature on. So I think that's like talking with each other and your experience. And so I've increased my recommendations in the last 6 months. And what my baseline used to be a series of 3, and I've changed my tune a little bit. And I said, if we're trying to resolve a problem and we're not in maintenance, I want to do 5. And if we're in maintenance and our goals have been achieved, then we're doing 3. That would be like, of course, there's a few exceptions here and there, you know what I mean? But that's kind of where I've moved to. Because I felt like with cases that were more challenging, the 3 wasn't enough. And so I want to set owners up for 5. I have done it as many as 8 on difficult cases. One in particular, I just last week recommended we circle back. It's a medically managed cruciate, and the dog wasn't getting worse, but wasn't getting better. And at exactly the 6-week mark after we started Shockwave, like boom, she turned a corner, and I said, okay, there's our Shockwave doing its job. And then 2 weeks later, she had a pretty significant setback, and she's been slow to heal across the board. So I had a conversation with owners, and I just said, she might be one of these outliers that needs 8. So let's do a few more. Yeah.
And how do you make the decision of
no,
when
you can
you're
take
kind
the
of at a
point.
baseline? So
Well, that's a great,
series.
yeah, that's a great question, Cindy. So like for me, baseline is that we've reached all of our goals and we're now just trying to maintain them.
And
Mhm.
those goals are defined to the customer and like usually functional goals, correct?
Yes, yes, we decide them together. So that's not just the owner, it's me and the owner together say, well, and I just ask straight out, like, what's your lifestyle? What do you want your dog to be able to do? I try to guide an owner into realistic goals on both extremes. Some people are, in my opinion, can ask too much. They want their 12-year-old to do a 14er after TPLO surgery. Like that's a big ask. And some people don't ask enough and they think, well, gosh, after a TPLO surgery, my 3-year-old, I might only be able to do 1-mile walks, and I can expand that view and say, hey, I think we can do more if you would like. And then of course, yeah, functional goals. And then I like to, I guess the only outside thing about functional goals is when I palpate the animal, I want them to be pretty dang comfortable. Yeah. Because
What's
sometimes,
your interval?
what's that?
What's your interval of these treatments, these packages?
I've
Initially, if you do 3 to 5 and then every 3 months thereafter, or you bring it up to, you said 5 treatments for a cruciate under some, or TPLO under some circumstances. What's your criteria at this point and what's your intervals?
And you ask really good questions, Beba. This is another one that falls into like, we don't have a lot of literature about this.
Right, I know
There
the
is
reason
none.
I'm asking, right? I'm doing the same things that you're
Okay.
doing, so I'll
So-
share what I'm doing, right?
Okay. Well, so this is like my opinion, and then I want to hear all of your gals' opinions too. Putting it together, and just for clarification, Babette, I feel like if we have a clinical problem that we're still managing, I'm asking for a series of 5. And then once we're in maintenance where we're happy with our outcomes, my follow-ups are 3 sessions on average every 6 months. If they're a really bad case, I will follow up every 3 months. Or if they're a really bad case at the get-go, we might do more than 5 sessions. And that would be like a general recommendation. I definitely have some owners that are due to cost. Their initial series is only 3. That happens sometimes, but I'd much rather do 3 than none. I still think we get really good outcomes with 3 for a lot of cases. And then you asked me the frequency of it, right? So I like to do Shockwave every 7 days. What I tell owners is every 7 to 14 days within your series. I don't like to go outside of 14 days. If scheduling is challenging, I will Shockwave a dog every 5 days, because sometimes they come in on a Friday and then the next week they want to see you on a Wednesday. And I did, there's a lot of human studies that look at the every 5 days. I'll be honest, I read those studies of many years ago, but that's where I came up with the 5 days, as I want that spread in between. Admittedly, I have Shockwave my own ailments every 2 to 3 days with good outcomes and no soreness. So if I would be open to doing it more frequently if that's what I had to do.
Okay, well, I just, so as we're sharing, I've been trying to do some of my older dogs every other week. Because I find that I can do an acupuncture treatment with stim, and that gets the treatment phase longer and they seem to last for a while, but at the end of the 14th day, they're ready for another shockwave, particularly if they have front end injuries. I find that their elbow and shoulder injuries are much harder to manage.
Yeah.
Right.
I have a question for you, Babette, because with the senior dogs, I wanted to talk about exactly what you said. And I call it ongoing shockwave, where there is no series. We just have an interval. And I've been having really good success with that. But my question for you is, when you're doing every other week shockwave and every other week acupuncture, are you staggering them, or are you doing shockwave?
No.
Yeah.
Right. What I'm doing, and I came up with a protocol on my own. I don't know how creative it was, but I'm doing shockwave with laser as a treatment, because I find after the shockwave, whatever I didn't get, or if I need to relax certain areas, I do the laser on top of it. And I have a class 4, one of those, fancy lasers, expensive lasers, and it works. It seems to get them very comfortable with the whole treatment. And then on the alternate week, I'm doing electroacupuncture with the laser. And I'm finding that they do, particularly with my front end injuries, my cruciates are another story, but my front end injuries are much more responsive to an every almost 2-week modality. In other words, if I go past 2 weeks, I got them limping again. And in some cases where I've had to stop Adequan, and I don't know if you've experienced this, I use a lot of Adequan in my practice, but what happens is they get very sensitive, and no matter how many probiotics and prebiotics I'm using, on the day we use Adequan, we seem to have loose stool, and in New York City, no one wants to pick it up. So, right. Now, we may laugh, but that's real. It's not like you're taking them out in the grass. You're sometimes having to pick it up on the sidewalk. So I've had to sometimes suspend Adequan usage, and depends completely on the PZO wave and electroacupuncture. So that's the protocol I've come up with for those hard cases. And I'm kind of wondering, is that too much? One of my older dogs had a vestibular incident. That was, by the way, 2 weeks after a treatment. So I know it wasn't related. It was unrelated totally. And then I got enough acupuncture done that after 2 weeks, she's back to normal. But that was a little frightening. And now I'm afraid to go back to use the PZO wave. So I don't know if those are some of the side effects we should be looking for as practitioners, whether we're going to get some of these older dogs to have vestibular incidences because of the shockwave, or all of this is so new that, I'm kind of just like you are, muddling my way through it. And yes, I notice if I'm working with my own hands, it's an every week. I'm trying to get my own hand arthritis under control, that I do much better off with every 7 days. That's what I find, but that's the human side of it, which is kind of easier to control than our own cases. That's all I have to add, right?
Yeah.
Has anybody else seen any vestibular issues? I have not heard of any. Any of you guys as practitioners?
I have not.
No. Katie's no.
So it wasn't related. It's probably not related.
Who knows? I mean, do we really know? But
I don't know.
I wouldn't suspect it to be. The only time I've had any type of a funny reaction in even that range is cats with seizures. And when they were treating up near the neck and super sensitive cats.
Okay, thank you.
So.
Yeah. And I've shockwaved cats on the neck pretty assertively and haven't had any side effect.
Yeah,
for the few.
It's hard to relate directly.
Yeah, it would be, you'd have to work pretty hard to get your pulses right at the vestibular nerve. You'd have to come up under the ear, you know what I mean?
Right.
To really get in there. So you'd have to work pretty hard to do that. And that's, of course, making an assumption that that's what it would require to create a vestibular event that would be negative, right? But my gut feel is that it wasn't related by that.
Yeah, that's what I think too. But I just thought I'd run it by, it's a 13-year-old golden, so lots of variables.
Yeah.
Yeah.
I like what you bring up, Babette, and when Cindy asked me to do the senior dog as the topic, I was excited because, funny story, I like to experiment with the shockwave, and so I started doing what I call ongoing shockwave, which it sounds like Babette you're doing too. So these are dogs that have extensive clinical signs and they're often older, and so instead of doing a series, I'm just indefinitely doing shockwave.
Right,
and
that's what I'm doing.
Yeah, and I found that I was having some really good outcomes. And then interestingly, my good friends who also do shockwave and a lot of it were also doing the same thing and finding really good outcomes. And this patients we were choosing were often our seniors. So I thought it'd be a good idea to sort of spread for folks who haven't considered that yet. I think the way I'm choosing those cases, it's often a dog, I'll do a series, they'll respond favorably, but then their response will fade pretty fast. And I'll say, okay, they're responsive to this modality, because we know not everybody's responsive to every modality. So we want to know that, but it didn't hold that long. And so, and those are usually in kiddos that are pretty, have extensive disease. And so I've done it in LS. And I did do it in like end stage arthritis in both elbows. And we did that dog every week. Gosh, I don't know, for well over a year. I never had any side effect that I could perceive with him. And he was probably some of the worst elbows I've ever seen. So we were just trying to keep him going. And I thought that I know the shockwave in those two cases in particular helped those dogs. And we offered it as ongoing. The LS we did every other week, the OA elbows we did weekly. And what I ended up doing business wise as kind of a reward for committing to ongoing is I gave them the 20% discount for that commitment, which just sort of felt good to do and felt like the right thing to do. I don't know what you gals charge for your shockwave, but it seemed to be fair to do it that way. Yeah, I don't know. Anyone else doing that?
I know we are recommending now in when people ask us about pricing, some sort of a senior rate or a senior package so that you can keep those dogs that need it comfortable.
Mm-hmm.
I don't know, is anybody else doing that? I know we talk about it often.
In New York, that's, well, I'm a house call vet, so the consideration is I'm dragging the machine and all the equipment, and quite honestly, I try hard not to discount, even if I have to elongate the periods in between the treatments and do electroacupuncture to keep the dog going, and then, intersperse with the heavy equipment. And that's mostly because I feel as though it's, number one, it's time consuming. Not that I resent that, that's part of treating animals, but it's something you really have to pay attention to when you do. It's not like sticking needles in and attaching the electrodes or doing a little laser. You have to see what the response is and how the dog is responding at that time. So it's a little bit more of an extensive a treatment. So I haven't felt like I wanted to discount it. It's also New York. So I'm blessed. And I don't want to make light of that, because I'm in a unique situation, and I wouldn't try to adapt what I do to what you do in a situation where we don't have that level of economic prosperity as in our general population. That's just kind of the way it is here. So I feel as though, with the traffic and everything else, I got to get paid. That's just me. So I don't know how everybody else is finding their time with dealing with the PZO wave, whether that is a consideration for them as to the pricing.
And I was going to ask Katie, and she disappeared because she's kind of in the middle of the northwest nowhere area. And it obviously is demographic. Kim, how are you guys doing with your numbers of treatments and your pricing and all that stuff? Are you busy and everybody's happy, or people? She doesn't have her audio on. See, that's what happens.
Oh,
Kathy's mobile, but she's California. And I think Kathy's driving because she keeps going in and out. I think the hardest thing, what I always try to boundary, what I'm recommending now, and you girls can tell me whether it makes sense, is I'm saying to people to boundary the shockwave in between twice of the laser and slightly less than your acupuncture. My reasoning was always that it doesn't have to be used as much as the laser. And also it can be a technician driven modality. Does that make sense to you guys? Is that where your pricing falls, Wendy, a little bit?
A little more than that. I charge more than that, Cindy. I think just a little than what you're recommending there. And so what I charge is I charge $175 just to like get the shockwave out and do one location. If you and my acupuncture, well, I charge by the hour. So if an hour of my time is $172. So they're equal. Let's just call it equal, right?
Mm-hmm.
And so if you want 2 locations, then it adds $75. And if you want 3 locations, it adds another $75. We top out at 3 locations, in that if the dog will sit still for long enough to let me do 4, I won't charge you extra for 4 after 3, because that feels high to me. So my pricing is really $175 for 1 location, $250 for 2 locations, $325 for 3+. And there's a little bit of gray area in there in terms of like when I have a very petite dog with bilateral, I'll give you this example, very petite dog with bilateral luxating hips. My technician can shockwave that dog 2 locations in pretty quick time. That dog is very well behaved, and there's just not a lot of real estate compared to like a big Labrador, let's call it. So we also do a lot of, I still charge for 2 locations, but I want to fill up that hour time because that client did pay for that. And that dog has a lot of, she also has LS diseases of Frenchie. So she's got a lot going on. So we just go ahead and add in some LS and paraspinals, but we still call it 2 locations. So there's a little bit of case by case for me in terms of the time spent, but that's like the basic outline. And then I give a 20% off for if you commit to ongoing. I've been doing all my own shockwave for 3 years. And then I hired a tech who I trained for a few months, but then was independent starting in January. And looking at my numbers, Cindy, with that, I'm doing way more shockwave because I have a technician.
Yeah.
And it's really great. I was estimating I was going to give her 10 to 12 cases a month. And just in May, I gave her 17.
Very good. Very good.
So I'm using it more because I can.
Yeah.
So I'm
That's
pleased to see
important.
that.
Yeah. Katie, how are you doing with charging and having enough customers and getting started with a new modality in a new area?
Well, I've been reaching for it a little bit more frequently than my laser, actually, because I feel like I get like more bang for the client's buck, and then they're not necessarily having to come back like for more laser. The shockwave seems to be stronger and last a little longer. I haven't done any like discounting at all, but I will say I really don't charge per area. I'm in Iowa, so right now I'm just charging $100 a treatment. And really I haven't gotten much pushback from that, but I do need to be better because I have a technician and a fitness trainer that we need to be getting some of like our own dogs out and them practicing with the areas and doing treatments themselves, because I would just love to not have to do it myself. And they're very capable, but it's been going really well. I've used it on kind of an interesting case that the people didn't know what to do with it, and they didn't really want to go and get a CT. It's like probably a 70-pound pit bull, like the kind that have the basketball heads, the really big, like pitties. And he has some TMJ issues that when he yawns or if he like opens his mouth too wide, his jaw will get like locked open until he like unhinges it, but he's learned just to not open his mouth that far. Obviously, well, maybe not obviously, but he's also super aggressive, so he's very hard to treat. We put a basket muzzle on him and feed him peanut butter through the muzzle, and I'm able to like get the trode right behind where the muzzle sits. And we've done probably 5 weekly treatments for him, and the owners are like, he's opening his mouth wider, like he's not like he's yawning actually. So I've had really good success with that, and literally I was making it up because I was like, I don't know, let's just try this.
No, we do that with the horses because obviously the high-end dressage horses have really bad TMJ.
Right.
Yeah.
So I
And
have,
like,
and I've had people do it when I've done a demo. It's really kind of scary, but they've seen it happen.
yeah. And I mean, the whole thing is like a bit scary. The first time the dog came in, I was like, I can't actually like touch this dog. So like, I'm not sure how I'm going to get like close to his facial region to actually treat him. But yeah, so that was one that, I mean, they started, so I think they'll be like kind of ongoing, but we're starting to kind of taper back a little bit. So rather than treating every week, we're going to go to every other week. But a lot of these like arthritic patients that I've been getting for like pain consults, we've been doing just shockwave and underwater treadmill like off the bat, and then having them come, you know, trying to get them on board for weekly hydrotherapy, and then we just add in the shockwave when they're there. That's been working pretty well. But I guess I do have a question for you, Wendy. When you're treating these elbows, can you share what your protocol is? Because I have a couple of new elbow cases that we've been using the shockwave on and they're responding well, but just wondering kind of what your technique is like.
Yeah, for sure. So I do three different areas that I focus on. I focus on the biceps tendon of insertion. I focus on that medial compartment, like where you would push to check for medial compartment pathology. And then also I come up to the medial epicondyle and I fan in a semicircle, that like the more distal semicircle where all your carpal flexors insert. Can you picture that? Yeah. The other thing that I do is I do what I call a layered approach. So I always use two heads. And in the average elbow, I'll use the 5mm and the 10mm. Because I guess in my mind, I feel like I'm treating a 3-dimensional tissue area. And so I want to be going not just into the different areas, but also slight different depths. I might use like a 15 and a 10 and a giant breed, or an animal that has, you know, those elbow dogs that have massive elbows. They're old and they're huge elbows. Yeah. So then I might go up to a 15 and a 10 rather than a 10 and a 5. So I'm just trying to kind of gauge where my pathology is the worst. I am a heavy shock waver, which Cindy can attest to. So I do no less than 4,000 pulses per joint. Wow. And what I like to do is I sort of choose which head is my priority. And usually the 10mm head is my priority. So I will do 1,000 pulses over each area. And then I'll take my lower priority head and do 500 over each area. Technically that's 4,500 pulses. I know the math, but the reason I am such a heavy pulse giver, well, there's two reasons. I shockwave myself a lot and I go really heavy on myself, and I've never made myself sore. And I haven't made dogs sore with my heavy pulse number. The other thing is I know the piezo wave is so accurate, and I know that there's a percentage of my pulses delivered that are not what I call treatment pulses because I'm off. This jelly click, I look away, the trode moves, the animal moves, you know, so I know there's got to be a certain percentage of human error. And so when I'm giving 4,000 pulses, I'm really hoping that 2,000 are perfect. Do you know what I mean?
Yeah, that's something I always try to talk about in training, that more, don't be shy of doing a little bit more, because when the dogs move and you're having, or as a technician, you're having a bad day and not feeling the right anatomy.
Mm-hmm. Yeah. And I've gone higher than 4,500 in a dog that's like moving so much. I know a lot of my pulses have missed the mark. And so I'm not shy about that. On places that are really easy to be accurate, for me, that's LS is the easiest. I feel like I can like stick with my 4 grand there. And I'm happy to share with you what I do over LS, which, because it's not quite as clear cut as a joint specifically. Something new, Katie, that I'd love to see if you gals do this. So I did this shockwave talk for these, a group of GPs a month ago. And so I was just like dabbling in the literature. It was like not a deep dive at all, but I refreshed my memory on some older studies. Well, one was older that I read when I was a baby doctor, and I like wasn't experienced enough to really assimilate the information and use it. But then I saw that old study and then a newer study, and it was really showing it had 3 cohorts. So one group, I can't remember, it was like chemically induced OA, I believe, in rats. And one group got no treatment. One group got shockwave into the joint, like they were aiming into the joint space. And I think it was cruciate, right? So they tear the cruciate. I can't remember, they transected it. It wasn't chemical induced. So they transected the cruciate. One group had no treatment. One group they treated, like they flexed the stifle and try to get into the joint where the cruciate is. And the other group, they actually treated the subchondral bone, like that was their aim. So they literally took the trode head and that nipple, they dropped it just a few millimeters below the joint line and fanned there. And that group had better resolution of cartilage damage, that hyaline cartilage, than the group that got the shockwave into the actual joint where they were aiming at the cruciate. So I think this is super interesting, with especially for our OA guys, and it has changed how I do things a little bit. In the elbow, it hasn't changed too much because the anatomy of the elbow, you're all over that subchondral bone when you're fanning that medial compartment. Can you picture that in your mind? But it has certainly changed a little bit of how I do my cruciate dogs or MPL dogs, where I'm still going into that joint space, let's say for a cruciate, but I'm spending some pulses drop down into visualizing that subchondral space, both in the tibia and the femur. So that's a new thing for me in the last month. And I don't know if you gals have read any of that stuff or have tried that, and that's what you naturally do, but that's something a little bit different. I've just tweaked.
I know we talk about now I talk about the 3 pads in the stifle, and the deeper pad actually trying to get it into the subchondral bones through an angle, for sure. But I think it's a true example of how important the positioning is, right? And when we try to compare different studies or different outcomes, or one dog has a different outcome from the other, I always worry a little bit about our positioning. It's hard to get the exact positioning, right?
Yes, I totally agree with that, Cindy. That is a variable that you cannot control. And it's like dog dependent, operator dependent, day dependent, because some dogs are easier than others. Sometimes you're having a good day, bad day. But I've tried to change, like my cruciates. What I taught Dina to do is, one of the areas is we would do the joint line, the medial joint line. And I've tweaked that. And I said, instead of the joint line, I want you to drop down 5 millimeters and do the cranial aspect of the tibia from the tibial crest all the way medial. And then I want you to do the distal aspect of the femur on that medial aspect. That would be for a cruciate. If you have an MPL, I'm going to run all the way around the patella and probably more of the femur on that lateral aspect and cranial aspect if I can. So it's like the tiniest little shift, right? But you can feel the stifle joint line with your fingernail, And so it's just that instead of aiming right there, you're just dropping down a few millimeters. Does that make sense to you gals at all? That's kind of like how I picture it. So trying to make sure I'm hitting inside the joint, but also just into the bone.
My one caveat that I say when we're hitting the subchondral bone and the cartilage, and I don't know if you feel that this is applicable or it's just my crazy biologic mind, and saving time and money. If the dog is 14 and there's no cartilage left, then I tend not to try to aim for the bone as much. I feel like I'm not going to make as big a change, and I tend to say, listen, let's spend more time in the synovium and getting that inflammation out.
Yeah, Cindy, I would agree with you that those are like the small tweaks. That's like the artful part of using the shockwave in medicine, right? Because I have to say, like, if I had a brand new traumatic cruciate tear that I wasn't really suspicious of a lot of arthritis, and I'm trying to preserve the meniscus, and maybe it was a partial cruciate, so preserve that ligament, I might send all my pulses into the joint for that dog. but you better bet not follow up 6 months, 12 months, 18 months later, then I am going into the bone because we know that arthritis is developing. So I think it's just like kind of understanding the pathology and then using your shockwave for whatever makes the most sense for that particular stage, right? Yeah.
For pain relief part, so I always in my mind have to separate pain relief from healing. But in the joints, when you're looking for that 3 days of pain relief, which we often do get, do you feel that's coming from the anti-inflammatory effect or something else? Curious.
I mean, I guess I'll go first on my educated guess. My educated guess is that it's coming from the anti-inflammatory effect because it goes away.
Okay.
And that the long-term pain management effect is from the body's restarting of healing. So that is an educated guess.
Well, no, that's where my brain goes, but my brain's a little crazy. So what do you think, Katie? Have you had any experience with the pain relief and where you feel it comes from more or less?
I think I kind of agree that, that short term is probably the anti-inflammatory, and then it kind of like is kickstarting the body's own healing process. So I would agree with Wendy.
And Babette, you're getting that 3 day of pain relief, correct?
I'm getting sometimes longer, but from my memory of dealing with it in the equine area, and down at Penn when they first introduced those big heavy machines, they were really shocking the nerve so that the nerve dropped the chronic pain sequence. And that's the initial response. In other words, those machines ran at a higher rate, and we can set our machines at higher rates to do that. And then you're getting the intermediate response of increasing the or decreasing the inflammatory response, which would in turn get your own immune system going. But that takes a little while. I think initially you're really killing the chronic pain response by shocking the nerve.
So you go to the pain pathway.
I definitely, all of those years that I saw it work, and they would actually put them on the disabled list and they made it 14 days after a while. They weren't fooling around because these horses wouldn't feel those legs.
Well, it's worse now. I think it's like a month before they can even exercise on the track.
Well, at that, I mean, unfortunately, I've been around a few days, so I only remember in the beginning when they first started to use it, even down at Penn, and it was experimental and they were playing with it. And I think that's the initial response. It's really taken out that chronic pain response big time.
Makes sense. I mean, I think it ultimately probably is obviously a combination of many things. I just, when positioning, I try to ask myself what's causing what, and that's just my crazy brain asking myself questions. So.
No, I think you're all right, but that's what I think your initial response is with the analgesia, and that's when the nerves start to wake up. That's when we lose that analgesia.
Okay. Babette, I think that's super interesting. Sometimes if I'm doing a combination visit with a patient who's going to receive shockwave and acupuncture together, I usually elect shockwave first because I can do a more assertive acupuncture session after. I find that.
To be very honest with you, what I have done is I am not doing acupuncture in the same treatment. Now, everybody has to decide what works best for their cases, but I have found that's somewhat redundant. So I'm doing the shockwave one time, and then I'm doing the electroacupuncture another time. And also something I do that I've discussed with Cindy, I use the machine in a little bit different way. Not just do I deal with the cruciates and the elbows, and some of your points are very well taken to deal with the medial compartment, but The other thing that I do is because I'm very well schooled in acupuncture, I use the piezo wave in small amounts over all of the significant acupuncture points. And she said no one else was doing that. So I'll take the master point of the hind end and I'll give it at least 1,000 shocks, as well as taking care of the hips and all of the other spinal nerves that I can clearly identify that are giving the dog some pain issues. And I find that that's really working for me, besides dealing with their knees and their elbows. So I've kind of taken I've taken acupuncture out of the treatment when I'm doing piezo wave.
And what I thought was interesting though is that it makes sense that if we're stimulating the nerve, we get an immediate pain relief response, which would fit with why I can do a more robust acupuncture session over tissue after I shockwave it.
It makes perfect sense. You're right. I just found that it was kind of redundant and it was time consuming, and that I was finding that on the next treatment, I would actually do the acupuncture. So I know that that's a continuing ongoing relationship with the client.
Yeah. It's interesting. I've been toying with this idea of doing a brief shockwave for my dogs that I'm really want to acupuncture, but they're struggling with accepting the treatment, and just doing 15 minutes over the area and see if I can gain a little, tolerance. And it's not behavioral. It's not these dogs that are behaviorally intolerant. It's because you can tell that they're having a strong pain response to the needle insertion. And so I've done a few experiments to be determined if that's going to be helpful.
Well, I had a really interesting experience with Deanna when I was watching her with a dog that we were doing multiple areas, and I think it was a toe, which obviously is sensitive. And I mean, she couldn't get more than a couple hundred pulses into it. And then we went on and did the rest of the spots and areas. And when she went back after that initial kind of nerve, I guess what we're talking about, nerve response happened, when she went back, she could get a full treatment into that area that was so sensitive in the beginning. She could only get a few pulses. And then literally 20 minutes later, it was like the dog was like, oh, treat this now.
Interesting.
And I was like, wow, that was kind of crazy. I think it's a combination of multiple ways. So Wendy, with your senior dogs, I have one final question with your senior dogs, your senior back dogs. Are you shockwaving the backs now? What are you doing?
Great question. Yes. I'm having the best outcomes with cervical and LS.
Okay.
And so I do a lot of cervical and LS. And then for my kind of otherwise T3 to L3, I'm doing more of like a myofascial treatment for them. Okay. And what I've found is that the shockwave's been really helpful with pain management. Not quite as much with changing neurologic deficits.
Right.
Although occasionally I'll see a slight improvement with hind limb paresis with LS dogs. So that's been my experience. I've been impressed with the cervical pain. I just used it the other day, a dog that was having a bad cervical flare up, screaming out all this. And I shockwaved him and he finally rested his head. He was, those dogs when they're so painful and wound up and you can feel their body relax. So I would say 1 minute into shockwave, he finally relaxed his body. And then I was able to do a really nice acupuncture session on because his cervical musculature wasn't like this, Yeah. So I used my shockwave to get him to relax and so I could do a really nice session with him with acupuncture. So I piggybacked that, and I did that 3 times for him. And that dog in that picture, she's a cervical dog who she responded really nicely to flare-ups. Her cervical flare-ups would be quieted. Even with one session, I'll do that. Although I would do a series with her. But anyway, so yeah, I don't do as much with my T3 to L3 kiddos unless they have so much myofascial dysfunction.
And what's your LS program or protocol?
Okay, protocol. So same layered approach. You pick your 2 heads. We're going deeper, typically, especially in big dogs. Sometimes I'll reach for 25, depends. In some of my big dogs, or if they're big and overweight, I really want to get, there's just so much tissue on top, you know, if they're old and atrophied, you know, you take that into consideration, right? So, but I have been doing, if they're a small, frail dog, as much as like a 10 and a 15, or sorry, a 5 and a 10, but it's more commonly like a 10 and a 15 or a 15 and a 20 in our average size dogs. Okay, so protocol would be, I'm doing L7 to S1, and I'm doing 2,000 pulses of each head. So that region gets 4,000 pulses. I'm sending the pulses straight down from the top partially, and then partially in at a 45 and partially in at a 45. So we do some fanning. I do that same thing L6 to L7 because I find that disc space often is involved. And then I'll do half of that at S1, 2. So 1,000 with each head at S1, S2 space. That would be like the core of my LS protocol. And then I usually have more time because the palpation there is so easy and the dogs are so comfortable with shockwave over LS. So then I'll kind of pick my extra spots. Sometimes I'll come up and around the sacroiliac joints. Sometimes I'll drop down into the sciatic groove, especially if they have like a lateralizing lameness that really seems to have some nerve root impingement on one side, or it could be both, I suppose. But if I feel like that's a huge part of clinical picture, peripheral nerve root impingement, then I'll do sciatic groove to try to get sciatic nerve hit. That's kind of my extras. But I always do L6, 7, L7, S1, S1, S2, 4,000 pulses in the first 2, and then 2,000 in the S1, S2, 2 heads.
Interesting. I've never done the S1, S2. That's just, I never considered that. So that's a good information for sure. And then
you were asked, the LS is the only place that I have a pretty strict rule that on intensity. And so when I first got my shockwave, I made 2 different LS dogs pretty darn sore. I didn't hurt them. It wasn't permanent, but it was a little bit disturbing. So what I've learned with the focal, I call it the focal head. You know what I'm talking about?
Yep.
Okay. The focal head, I won't go above 4. It used to be 3. I got brave. I pushed it to 4. I've had success. Will I ever go to 5? I don't know. We'll see. And then I just crossed that over to the linear head. So if you were to cross check the intensity there, you can go to 12 on the linear head. That's equivalent to 4 on the focal. Does that make sense?
Yep.
So I know my friends in Fort Collins have also found the same thing with soreness over LS with high intensity, not so much with pulse number. So it's always nice to know you're not the only one that has seen that.
Anybody else have any questions for Dr. Wendy? Everybody seeing healing and pain relief, so that's a bonus. And as we always try to preface, and I don't know if any of you have been on the website recently, but the blog part of the website is growing when Cindy's at home, not when she's traveling. But we do have a dosing blog up there, and we do have I'm just putting the dosing blog up, but we have an energy blog and some other things. And you know, my point in writing all of this is I include the references, but the fact of the matter is it's safe and there's no right or wrong way. So
no, I really appreciate this because I've not gone over 2 in my LS treatments, and I've also treated S1, S2 and very successfully, but I don't go above 2. So now, you know, I'll try to go a little bit. I was always a little afraid because I don't want to make them sore, right? Because that's contraindicated. But they do so well. I mean, I've literally had dogs that could hardly walk or couldn't walk, got carried in, and after a treatment on the back, literally walked out of the office. So I've seen such great things, but I will try, using that focal head in with a little bit more intensity. Thank you.
Bevette, I have a question for you. What are your favorite acupuncture points to shockwave? Because I'm going to try this.
Okay, well, figure that you're going to do, it's just the LS thing. In other words, you're going to do bladder 23, right? Which is equivalent. In other words, you're just doing your LS treatment. I'm listening to the whole thing. I'm just saying, okay, I'm going from bladder 21 to bladder 27, and I'm angling, and I'm doing sometimes 500 shocks to 1,000 shocks at each point. And then I'm doing the S1, S2. Sometimes I only do maybe 500 to 1,000. I don't really go overboard with those points. And then obviously I do the hip points, which, everybody would do the hip points. That's not a big deal. And then I do, which I find extremely effective, the master point of the hind end, which is the gastroc, and the that whole apparatus in the back, with the is right at the back of the popliteal crease, is really a great point. I learned that a long time ago with the horses. I could make them run faster. So I angle that probe up and I angle it down to get the insertions of all of those tendons in those areas. And I go, and Cindy had suggested I go up and down with that probe, and I find that that's even better. So I take my points, and then I kind of embellish them to do the same protocols you're doing, but it's over a bigger area. I also do, when I'm doing elbows, just as an aside, I also do over the biceps tendon, the infraspinatus and the supraspinatus tendons, and those insertions, and down that arm to the elbow. And I find that I get better relief from those elbow dogs. So I'm taking all of those points that I normally would stim. I would put a needle in and I'd stim that shoulder, but I'm now using the piezo wave over that area. Now, I'm not using a high intensity. Sometimes I'll come down to 1 over those, because it's very superficial, those tendons, but I find that's extremely effective, and that's releasing the tendons that go to that elbow. In other words, I'm not just dealing with the elbow, because I find that doesn't necessarily give me the relief, because they're actually cramping up higher up. And maybe the pathology is really a biceps tendon or an infraspinatus or a supraspinatus tendon. If that's any help.
Yeah, with the elbow dogs, do you do LI11? I mean, that I need
absolutely.
That.
Yes.
Because I think that that's like my go-to favorite elbow point is LI11. So maybe shockwave that a little bit and see.
I find that it's really working for me, and I'll come around the neck in the same way. Now I've been a little hesitant to do. I don't know that I would have been as brave as you are to try to deal with the jaw like that. I think that's great that you did it, and that's a difficult dog to do it on. I'll try it, because sometimes we do see that pathology, and it is hard to acupuncture, when we've got that lockjaw kind of concept, right?
Interesting. Cool. Well, I really appreciate everybody chatting and learning from each other, because I mean, again, that's the only way we're going to get better at this, and there is no book. Sorry. You don't know how many times people say, but I can't press the button that has a picture of the dog and where I want to treat it.
I don't even use my laser like that with the picture. I mean, it's all the depth of the dog, the pain level in the dog. And I'm sure we all have that level of experience now, but to have the actual points, and actually figure out what the intensity should be, that's really great. I mean, that's great information, because I didn't know I could maybe get the treatment to last a little longer by using a higher intensity.
Yep.
Thank you.
Oh, it was great. Wendy, I always love to hear your magic.
It's our best guess, I suppose, right?
No, but that's, as long as you have a why, then it's not a guess. There you go. And it's legal. Now, if you don't have a why or a what, then it's a guess and it's not legal. There you go.
That's true.
But if your brain is thinking, it's not a guess. You guys are smart. So, you know,
How do we get to the blog? I hate to be, I've never done it. So.
if you go along on the website, along the top bar, there's a tab that says resources that's black.
Okay.
And then that takes you to all the content that's the US content that we have developed in the last 2 years. And then in there, there's another, along the top bar of that tab, there's a blog tab. We had to improvise because we had to work through the German website. So basically, that little black button on the right is all the current kind of evolving trends that aren't legal to my medical director to be speaking about. But the world isn't straightforward, and we wanted you guys to have all the information and make your own decisions. So there you go. But the website can be a little hard to navigate because of that. But if you just go to the black box in the right that says resources, that's where your, you know, kind of fun, interesting, different. That's where these forums are posted. That's where blogs are along there too. There's all kinds of resources in there. So
That's great. Thank you.
but I appreciate your time and energy and effort. And this is what makes doing what we do fun. So good night all, and I appreciate it.
Good night.
Thanks,
Bye.
everybody.
It was wonderful.